Okay, let me see. Can you watch my screen?
Yes, teacher.
Yes, we can.
Perfect. So let me check attendance. Okay. Let's go. I think it's enough time. We are. Let's start. This class is not too long. We're starting module 2. In that order, we are going to check lots of new information. Module 1, in my opinion, was easier because we had lots of vocabulary to memorize. Body parts, anatomical references, the name of pathologies, some physiopathological processes just as information, but it's important to check how to give that information. As I was telling you in previous sessions, in previous classes, in Module 2, we had the chance to start writing down more, and we have the chance to start giving information, giving reports, reading lab tests, x-rays, and information like that. So that's why it's very important to take attention, and to pay attention in this, to take some notes maybe, because the slides has less text. There are more images, and well, let's go. Today, we are going to check the basic contests about basic investigations. Basic medical investigation, okay? We must make a review, maybe. What is a medical investigation? The meaning of this term specifically. Sometimes we don't realize how important it is, because it's very common in our branch, in medical branches, to take care of this. Investigation as a word for recognizing the meaning and catching the idea is a systematic and thorough examination on inquiry into something or someone, the collection of facts or information, and the recording of this examination or inquiry in a report. Of course, we need to make a report about findings, about what we are looking for, and the process we are following for this. The word investigare can be traced back to the Latin word investigare, as a meaning to search into, and investigare is based in another Latin word, vestigare, meaning to track or to trace. So we catch how this word is done, how it is constructed. The same as the medical term, we follow the same rule. The medical investigation as a fact are all the complementary studies that we request in order to support the diagnosis. We all know we make the medical interview, the anamnesis, We take the information from the patient about complaints, about the symptoms, and we start collecting the most important details in order to check an idea and according our medical thoughts, we get into the diagnosis. But actually at this time, I mean, in this period of history, we can say, we need to support the diagnosis. Sometimes with X-rays, sometimes with labs, sometimes with another kind of studies. Well, it depends on the situation, of course. And in not all the situations, we can just support with our medical thoughts, because it's something not too complicated when we get on practice, right? In that order, we support the investigation, we support the diagnosis with the medical investigations. We have to be clear on this point. They are not the only process we use for giving a diagnosis. They have a clinical line that we follow in order to know which ones to ask for, and we support our idea with that. It's not the opposite. We don't start assisting a patient, asking for labs, X-rays, CT scan, things like that. First of all, we have to get an idea and then make the request. We all know about it. This joke is funny, but it's true. The doctor says this test is to see if we need to do more tests. I mean, we are not going to ask about everything in labs, right? We are not going to take all the information in a sample of blood, because sometimes it's not necessarily. We have to focus only on the important facts at the moment, and according to the results, if we consider it's necessary, we add some more. That's why basics are always basics and are a basis in the diagnosis. As a basic investigations, we have some procedures. We make the vital signs, we take the vital signs. We are going to talk about it. The vital signs, of course, blood pressure, heart rate, pulse, respiratory rate, core temperature, the blood oxygen, could be the arterial blood gas or oxygen saturation, and the ophthalmoscopy. I think that as a general idea, in Latin America, we don't have the chance to practice the ophthalmoscopy as a routine. But in other countries like USA, UK, France, Italy, Germany, India, you have the chance to get practiced on this, on the ophthalmoscopy. And it's considered a basic investigation, because if we make this procedure, we can find some details that can give us an alert, that give us the red bulb about a situation with our patient. That's why it's considered in the STARS procedures we as doctors must make. Of course, we have our nurse, our students that help us doing all of this first part. But by experience, sometimes if the situation is in accordance, if it's too necessarily, I repeat the procedure for being sure what is going wrong. I think all of you had the same experience. That's why we must take this into consideration. Well, we have the idea that the patient knows the monitor, of course, because we have to check the moment. Of course, when we take the vital signs, we have a overall snapshot at the moment. We can see that it's not a value that can be just the same all the time. It's changing according to the situation, according to the treatment, the pathology, the stress that the patient is suffering because the patient is at the hospital. or maybe the patient is getting relaxed, or maybe the medication is changing this. We all know about it. So we consider that this overall snapshot is just for the moment we are working on. We don't have to consider these values as a fact for the whole time that the patient is inside the unit, is admitted in a service. We all know about it. Alexander Tartarin is a nurse that introduced this idea, introduced this phrase, treat the patient on the monitor, because the experience he has on the American history in the nursing profession. And he is one of the most important nurses that develops this idea in order to be clear that we are treating human beings, that not objects. The monitor can be failing, can be not well connected. We know all the situations that could happen. That's why we consider that if these values are not going in accordance to our patient, we must make the procedure again, we must reevaluate. So take it as a general idea, please. It's very important to consider. Of course, our devices, one of the most important and the characteristic of a doctor is the stethoscope. And we all know, we get this history. We have to check this. If we know history, it's easier for us to develop a great job and make sometimes interesting our speech during with the patient, to get the patient relaxed, who knows, or just for making fun with our colleagues in our hospital or place of job. So the stethoscope, we all know that is Laennec. Laennec is the one who developed this device, because in the past, at the beginning, we know that that was the procedure, how it was developed. You should place the ear on the chest patient, no matter the situation, if there was bloody or, I don't know, with an injury or with a skin infection, you had to place your skin. That was not a trouble if the patient was a man. But Ronald Laennec decided to develop the stethoscope because when he was supposed to evaluate a lady, he didn't want to place his ear on the chest of the lady because of the historical moment about feudal, about the shame that it could be for the lady to be naked in front of the doctor. So using this, he checked that that was better for assisting ladies, for assisting women in general, and kids. That's why he was changing and changing the model of this device until the actual ones. In that way, Laennec said, and he noticed, of course, that using the stethoscope, infections were not as contagious as without using this one. That's why investigation made a great step. And he noticed that it was easier to hear the breath sounds or the pulmonary sounds with this stethoscope. We have lots of new models, of course, but in general, the parts or the anatomy, we can say, of the stethoscopes is this. As a general idea, in general, all the stethoscopes have the same structure. The air tips or ear plugs, the air tubes, that usually are metal tubes, adjustable binaurals, the binaural ring, this is the headset. We have the flexible tubing, the rubber tube. We have the stem, the drum, the bell with a hole, of course, and the diaphragm. The dual head chest piece, turnable diaphragm. You can switch one side to the other according to the situation, the patient you're going to evaluate. Just as a general information to take it in account, of course, we have at this time electronic devices, but it's not an objective to check how many differences we have. As a general view, we must remember and memorize this vocabulary because it's important. We all know how to know the names of the devices we have for working. Of course, we have the sphygmomanometer, the basic one for making basic investigation. No matter where you are, you have the chance to practice with this. Developed during the World War according to evaluate if a patient was or not in shock. And well, it was easier. And at this moment, it's easy to use. We just need practice to catch the sounds. And of course, if we don't know how to do it, we are not prepared for assisting patients. About the parts of the sphygmomanometer, we have the inflation bulb, air release bulb, of course, the tube connectors. We have the artery position or indicator label, left or right, we all know about it. We have the aneroid manometer gauge, the pressure cuff, well, the index marking just for checking how it has to be placed. So, it's a general one. We get lots of models. So don't worry about it. Just get on practice. Get on practice, memorize, of course, these structures. And let's go to the first one. The VP, the blood pressure. We all know how to do it. Well, of course, it's a non-invasive procedure that measures the pressure or circulating blood against a blood vessel wall. We know the physics about it, right? So we have to consider this, okay? We have to consider this and check. The top number is known as the systolic BP, and the amount of pressure that your heart pumps through your arteries and entire body. The bottom number is known as the diastolic BP, the amount of pressure that arteries and body when your heart is at rest. We all know about it. And please start memorizing the abbreviations, because from this point and ahead, we are going to use just abbreviations. We all know about it. That's how it plays, how it works. We all know, just for checking a general review of this. We have the electronic devices, how they must be placed. Of course, we have again the parts, the landmarks of this, the air jack, the display, stores stereo measurement in memory bottom. We can get a memory about the control we are doing, the start and stop bottom, of course, and we have the marker again, the arm cuff, the air plug, and the air tube, just for catching a general idea. In this way, we all know how to place it. Two fingers from the line of the wrist. This is the correct place and the position it has to be placed again for taking a good value. It's not everywhere. It's not in the opposite position. It has to be placed like this. Just as an information for making a review, some models and details that, well, these tips for an accurate measurement, when things they do, things they don't do, you don't have to do. Details you have to consider before using this. For example, reading the manual. Sometimes we avoid this, but it's important. We must remember the rest for 3 minutes before measuring 3 minutes with these electronic devices. With the manual sphygmomanometer, we need around 5 to 10 minutes. It's according to the situation. Rest your elbow on the table and hold your wrist at heart level. We all know about it. This specific position, similar to the manual sphygmomanometer. And use only on your left wrist, not the right, because the difference on this value is important and can make us to get into a mistake about this value. It's different with the sphygmomanometer, the manual one. In my experience, according to the situation, you can use the electronic device or the manual device. It's your choice. And the boss says, the boss, of course, the American Heart Association was one of the most important societies that give us the guidelines about how to work on these controls and define into pathologies according to values. Just as an information for checking how it must be expressed, okay? Again, more details according to the age. Now check the heart rate and the pulse, of course. Taking this idea, we must be clear what we are going to do. First of all, this is the amount of times that heart beats per minute. You all know this abbreviation. This is the wave of blood created each time the left ventricle on the heart contracts. We all know about it. Each pulse beat is one cardiac cycle or one heartbeat. As a per medium, the normal heartbeat is about 70 times per minute. With an increased oxygen, it could be a faster rate pulse with tachycardia, about 100, or bradycardia below 60. Okay, so just as an information, general view. According to the age, we have different values. Just for making a review, don't worry about it. Check how it has to be expressed, how we use the abbreviation everywhere. You can see you don't have to write the full term beats per minute, just using BPM or /min, as we were checking in the previous module. Is easier to make it the same as in Spanish. Now I have the common pulse sites: radial, brachial, carotid, temporal, femoral, popliteal, posterior tibial, dorsalis peris, in Latin you can see, and the apical. The most common ones for evaluating the pulse. And the steps for measuring radial pulse. Just the radial one. These steps are for showing how to describe this procedure. Of course, starting with the hygiene, to exploring and explaining the procedure to the patient, asking for permission for touching him, and asking about physical activity, smoking, well, habits that we must consider. We must place the patient sit down and the arm in a comfortable position. We place the fingertips on radial artery on thumb side of wrist. We have to check the quality of pulse. We start counting pulse beats. We all know how to do this. We count the pulse for 1 full minute. It's the best. Sometimes we decide just to count 15 seconds and then convert or change the number by 4, and it's not correct, or maybe 30 seconds and add 30 seconds more by adding the information. It's not correct. We all know about it. And again, the hygiene for finishing the procedure. We all know about it. The respiratory rate, of course, we all know about it, but it's not an extra information to review it again. Is the rate which breathing occurs. It's usually measured in breaths per minute and is set and controlled by the respiratory center. We all know about it. We evaluate the pattern, effort, and volume of respiration. Maybe more in indicative or altered respiratory physiology. We know about it. several pre-hospital and hospital-based illness or injury severity scores feature the double error as a cardinal value. We all have this idea. In model 1, I'm not sure at this moment which presentation was. We have some charts with respiratory patterns. Check all of that information. It's very important, and check the way we use these expressions while talking to patients and explaining how the respiratory rate is working. We all know that pathological ways of respiratory rate have a specific name, and according to that situation, we have some specific pathologies. That's why it's easy our job sometimes, right? The steps to measure the respiratory rate or the respirations are general, of course. And we consider this the step 1. Well, again, the hygiene, we identify the patient, and we have to assist the patient into a comfortable position. We must place hand on the patient's wrist in position to take the pulse. We all know it for creating a distraction. We have observe and count each breathing cycle for 1 full minute. And then again, perform the hand hygiene and record the value. That's all. We all know we do it when we are at college in med school, I mean, and then we can talk about it. We can practice on this. About the core temperature, well, it's the temperature of the body's internal organs. A normal body temperature ranges between 36.5 and 37.4 Celsius degrees. But temperature readings vary depending on where it is measured, right? According to this, we all know that this variance is expected. And according to the situation, of course, it's the same. In this chart, we can see how it is changing according to the place we are taking the information. The fronts, the shin, the check, and different places to evaluate. And you can see how it's different just for taking it in count as an information. And it's very interesting, this study, because you had the chance to get a detail that sometimes we don't consider. The places we usually take the temperature are the oral temperature, tympanic temperature, the rectal temperature, okay, the skin temperature, temporal or frontal temperature, and armpit temperature. At this moment, at this time, sometimes we prefer to use the electronic devices. But these electronic devices have some differences from the mercury thermometer. The mercury thermometer is, of course, well, it's better in my opinion, because it's not going to change through the time. The device, it's not easy to get broken, I mean. In the electronic devices, if the battery is low, the temperature is not going to be taken in a correct way. So if you feel your patient in extreme cold and the thermometer, the electronic thermometer tells you that it's normal, of course it's not. Check again with a mercury thermometer, considering the situation. On the other hand, if you feel the patient or you see that has signs of fever, I mean tachycardia, tachypnea, the patient is sweating, is complaining of pain, consider that there cannot be a normal situation. So ensure yourself using the mercury one. They are placed in the armpit, or in the oral, or in the rectal, according to the head of the mercury bulb. And then it's gonna be a better job, I think. This line, it's not trustable because if you don't place it correctly or properly, if it's not as clean as it has to be, the skin or the device, it's not working properly. That's why I prefer not to use this, but it's your choice, your own choice to do it. Well, let's talk to the blood oxygen. We all know, very common at this moment. And we have the chance to use the fingertip device or by blood, by a puncture, the invasive procedure. Of course, the invasive is lots of painful. If you had a chance to feel how it hurts, I'm sure you are going to think twice before sending it to your patients. This is not comfortable. It's easier, but it has a difficult situation, we can say. If this device, if the laser is not working properly, if hands are too cold, if your hands are too short, I mean, kids require their own device, their own fingertip. If you're too small, if you have nail polish that is so dark, for example, blue or black, this control is not going to be correct. Why not? Because the laser that this device uses is not crossing the paint, for example, the nail polish properly, and it can give you a wrong value. Okay, if your hands are too cold, you have a constriction of the venules, of the arteries and veins of the fingertip, and then this is not taking the correct value. If you are too cold, it's the same situation. So there are some details to consider. Actually, there's one study, there's one article that reports that which finger is the best for taking the blood oxygen with the fingertip with the fingertip device. As a conclusion, it says that you must use this device on the middle finger or the thumb with the hand you write down, with the dominant hand, with the principal hand, we can say. If you write down with the left hand, use the device in the left hand, the middle finger or the thumb. The same with the right hand, the middle or the thumb. Why these fingers? Because they have the biggest blood supply, and it's better, it's trustable, the value for using this. So consider this as an information that is important for not making a mistake while preparing. Okay, while developing this procedure. Of course, if batteries are low, they are not working properly. You must consider that information. Some of them get in charge with the USB data cable, I mean, just to the computer or to charger. Well, you have to ensure that it's well prepared for using this in the way that it really needs. Well, the arterial blood gas, we all know that is an important study and research that we need for evaluating the situation with our patient, the gasometry. It's not as a routine, it's developed as an emergency in a situation, where an extreme situation, we all know about it. The blood oxygen at this moment is considered as a routine into the vital signs. That's why we take it in count. Well, talking about the ophthalmoscopy, as I was telling you at the beginning, it's a procedure that must be developed into the emergency room, according to the situation, of course, or maybe in the admitting wards with the patients that are admitted into the hospital as a routine. It would be better if we practice on this. And well, in Latin America, we don't have that custom to develop this. We don't have that practice because we consider that it has to be practiced just by the ophthalmologist, but it's not true. Sometimes we can find a patient with a chronic situation, just developing this, and we can prevent lots of situations. I mean, we all know it's a non-invasive procedure developed by a doctor, of course, not by a nurse, not by well, of course, the student that is in practice, but the opinion of the student must be supported by the opinion by a doctor. So we see in the emergency rooms at the USA that all of the patients that get in the emergency room are receiving this procedure as a routine, just for checking the situation of the retina and looking for some trauma, looking for chronic situations. If there's a patient with high BP, it's an obligation to develop the ophthalmoscopy. Of course, we use the ophthalmoscope, and this device allows the doctor to examine all the parts of the eye, the iris, the lens, retina, and the optic disc. As a general view, of course, maybe not as an ophthalmologist with all of the details we need, but it's very important to consider this and to, of course, to check the differences between the pathological from the normal one. For best results, the examination is done with a dimmed or lowered lights to allow the pupil to maximally dilate or widen according to the situation, of course. If we have the chance, we use a topical mediatric solution. It's applied to the eye to aid dilation. The patient is asked to fixate on a target for the duration of the test. If you have the chance to receive this mediatric solution, you know that when the procedure finishes, you cannot watch anything because the pupil is open, is dilated. You cannot walk because the whole light is getting into, you cannot watch. So you have to stay, rest, and when the medication is going away, then you can walk by your own. It's very interesting. I think at medical school, we all had the chance to do it once or twice during the ophthalmoscopy rotation, maybe, but after that, we don't develop this more, but it's a good idea to do it. As a general view, we have the parts of the ophthalmoscope, and we have the two phases, the patient phase and the doctor phase. We have the viewing window, the lens wheel, the lens power scale, the light adjustment collar, and the power base and handle for placing batteries. On the other side, we have the mirror, the color adjustment button for checking properly the retina and the iris, the aperture adjustment wheel for checking properly, not so big, not too small. It's just according to the practice you have. The light adjustment collar, of course, for sending more or less light according to the situation and the place you are developing this procedure. And again, the power base and handle. We all have to know these details because it's important. It's for us. We're not making a mistake. We have the direct method and the indirect one. In my opinion, this is the easiest because, well, you have to place on your eye and then look for the details moving and moving the device in your face. Not too comfortable to the patient. But the indirect one, of course, needs more practice and specific way to be prepared on the ophthalmoscope. It's different. This is the position. This is the general view and a schematic graph, I think. The macular area, the fovea, the blood vessels, physiology cup, and the optic disc. Just as an information for making a small review about the retina and the details we must look for. This is how the indirect procedure is developed. You use this extra lens and you move just this lens. It's just practice, but yeah, I never had the capability to do this. It's harder to me. I prefer the direct one. And this is a real ophthalmoscopy, a real one, and that's the change that the pupil gets when you use the topic solution for getting it dilated. That's the way you see inside, and that's the anatomical details you must check, and of course some changes. We have hemorrhage, we have blood vessels, the disc, the macula, and some exudates. Going ahead, just as an information, some schematic graphs, I think. We have the vitreous, the intravitreal, with details for checking, just as an information. The preretinal, the subhyalt, the thumbprint. It's according to a brain tumor. Then we have the preretinal subhaloid, typical single or small groups. Initially round, but becomes boat-shaped. You can see the boat-shaped. It obscures the retina vessels, the superficial intraretinal. Details for being sure that elongated with frayed borders, splinter on flame-shaped, just for checking this. The deep intraretinal dot or blot, you can see. The retinoschisis, non-comfortable situation. The subretinal, you can see it's from trauma. And the subretinal pigment epithelial or choroidal, dark slate colored, with a smooth border surrounded by a red ring. Just an anatomical detail again. It's according to a trauma again. And you have the diabetic retinopathy, the fundus imaging, just for information, for checking why it's important, and the anatomical details we must consider. We have the grades about different pathological situations. We have the optic disc edema. You can see this here. The intraocular hemorrhage. You can see this. There's some blood everywhere. Grade 3 and 4 for a hypertensive retinopathy. The cause of blindness, of course, we have to consider this. The retinal or vascular occlusion, you see. And the optic disc pallor because of a trauma. Consider this as a general information. And of course, we can practice on this. So taking this information, we have this ARN, yeah. Let me remember this. Acute retinal necrosis. It's because of trauma. When the retina gets free from the eye, and starts in the necrosis process. That's the way you check the fundoscopy. According to this, you can make a diagnosis of acute blindness. Sometimes it has a solution, sometimes it's not. You have the description on this, how it's checked, and of course the treatment is effective at this stage, not another one. And the third or the fourth, it's not possible to do something nice with the patient. And don't forget that the goal without a plan is just a wish. That's why we have to be clear on what we are looking for with the basics. And according to the basics, we have the chance to make a better procedure. So, considering the general information at the beginning, I think it's not a hard presentation. It's very easy. We all have to practice. We all have the chance to do it. And, well, that's all for tonight. Easy to make, in my opinion. Easy to work on this. I got a question at the chat at the beginning, and it says this: the diaphragm and the drum are the same. The drum or the drum? Could be the drum. Could be the same. There is no problem. Let's go to the slide. Usually, right here. The drum or the drum is the old structure, the metal one, and the diaphragm is just the white one that we can replace and change. If the diaphragm gets broken, we can take it out and the drum stays into the stethoscope for replacing again the diaphragm. Is now understood that? Because they are two different structures. Some stethoscopes have diaphragms that are placed and fixated there. And for changing the diaphragm, if something happens, you have to exchange the drum or the diaphragm. It's different. That's the metallic structure. The diaphragm usually is in plastic. In past was on leather, but now not. Now it's plastic. It's considered as better, but I don't think it's the best. Okay, let me send you the pool to take attendance. We have to take it again, all the classes. Okay, let me see. Can you all watch the pool?
Yes, teacher.
Perfect. So tomorrow we have the workshop. Of course, I'm going to send the slides, but I was talking to the academic supervisor, and we together decide just to send to the ones that are attending the class, because we have some classmates that are still in the group, but are not coming. That's why it's not fair to do it, to send to everybody. And well, if people is not attending, why I'm just sending the material that I prepared by my own, because it's not the institution that is sending the material, it's me here. That's why I prefer to send it just to the ones that attend the class, and I think it's better. Any question about it? No, I don't think so, right? On the other hand, according to the attendance we have tonight and the list that the academic supervisor sent me from the people who's coming or not, or leaving definitely, I'm going to prepare again the role for the workshop from tomorrow. I'm going to, well, from the list we have in the module 1, I'm going to take out the ones that are leaving And well, maybe the hour of someone is changing. If it happens and the time that it's for you, it's not doesn't fit, please send me a message tonight to correct it. I needed to get the role well done and completed as soon as possible to send it to the academic supervisor, and we are going to try to support this. If, for example, because of job, you cannot attend the workshop, or because you have a shift and, well, it's because of your role, you cannot attend, please let me know as soon as possible for not making a mistake on this. Is that okay in that way?
Okay, teacher.
Okay, perfect. I know that there are some classmates that have a specific shift on Tuesday and Thursday, just the days of the workshop, yeah. And I know that days you are not attending. So don't worry, if you're not attending that workshop, the next one you're going to have your schedule because we know about it. We are clear on this. But the rest of the people that is in a role, please let me know the role you have for preparing this list. The academic supervisor is asking for. About the general attendance of Module 2, of course, I'm going to take it in count. Maybe harder than at the beginning. Because, well, it's your score. It's my job to take it in count, right? If I don't take it in count properly, it's not correct. Any question? Is that clear at this point? Something you would like to say, maybe? Now is the moment to talk about it as a group, because maybe later it's not going to be possible. I need your roles, please, your shift roles. And I need 2 more students to fill the pool.
Teacher, I didn't hear about what you said about the role at the beginning. I don't know if you can repeat it, please.
Okay, no problem, Grace. I need your roles, your shift roles, in order to prepare which days you are attending or not, specifically the workshops and the theoretical classes, of course. I'm not going to send the presentation to the group because it's not fair that people that it's not attending the class receives the same information. It's not correct. If, for example, Grace, you have a shift tonight and you tell me that you are on shift, I consider that and I send you the material that I prepared, not the institution. I'm giving you the material because I know you don't have a book. But if there is a student that easily decides not to come to the classes because prefers not to come, well, at the moment I talk to the academic supervisor and we together decide to send just to the ones that are attending the class. Following your shift roles, I know which days you are attending or not, the theoretical class or the workshop. That's why I need your roles. I have 2 students who told me about the shifts, but the rest of the people didn't say anything and they are not attending. So please send it to me. Is that clear now, Grace?
Yes, teacher. So I send you my shifts by WhatsApp.
Okay, perfect. Thank you so much, Grace. I have yours, a general idea, but I need the dates for taking it in count because all attendance have a score. attendance to the theoretical class is on a specific score, and attendance to the workshops have another score, and I have to prepare this. If I have a reason because of the absence, I can help you not to lose all the score of this specific chart, of this specific activity. But if I don't have a reason, or the academic supervisor does not receive a reason, it's not possible to help you, not possible to try to save that score. Because of attendance, 2 students lost module 1. That's why we must consider this. Maybe another detail you would like to talk about. I send everybody, well, to the group, the key answer of the final test and the homework 3. I think they were easy to read, to compare with your answers. And as I told you at the beginning, if I cannot read your answers from homework or test, it's not a valid question. If you send me a file that is mixed, I mean, is not organized, I'm not going to take it in count. Please, we are doctors. We must be organized with our papers, with documentation, right? It's not correct to send me a file mixing the pages, or sending them in the opposite position, or one's well placed up and down and the rest in vertical or in horizontal position, because I cannot read it. It's harder for me for making the job. At this moment, we are 16, but on list for continuum, we must be 18. Read 18 files that had a mistake. It's not possible. The ones that have this situation, I sent a private message at the moment, at the beginning, but now it's not going to be possible to do the same. That's why it's going to be harder. Okay. Let's try to be organized on this point. Of course, we have the same as in the module 1, every week a file of homework. We must work on the case report, this full module, and that's all. Here we have to write the case report that we didn't finish on module 1. It's easy. Tomorrow we are going to talk about it. And the ones that I have to send you the details, the corrections, tomorrow we are going to talk about it. And next week we are going to start talking about lab tests, the reports you have to prepare by yourself, about labs and imaging reports, and the letter of referral. It looks harder, but it's not. It's very easy. So don't worry about it. You all have the practice, I'm sure about it. And I think that's all. All of you fill the pool because it's attendance. You know about it. Hello?
Okay, teacher.
Okay, if the ones who fill the pool can leave the Zoom session. If someone couldn't fill this, please tell me now for launching it again. So see you tomorrow in the workshop, and I'm gonna send the roll in 10 minutes, no more than that. Check this and let me see if it fits, okay?
Okay, teacher, thank you. See you tomorrow.
See you tomorrow, bye-bye.
Bye, teacher.
Good night,
See you
teacher.
tomorrow.
See you
Bye,
tomorrow.
teacher.
See you, bye-bye.
Thanks, teacher. Bye-bye.
Bye-bye. Ugo, can you listen to me? I'm gonna close this. Well, I think everything is said and it's done, so let's go.